Randy Welton, and we're going to be talking about the neurobiology of PTSD. And we're going to be following the neurobiology from the very symptom formation up through treatment and looking for that linkage that you would see. So this is something we're all going to see. I'm going to be using an example case. This is a real situation. Obviously, this is not a real patient. This is an amalgamation of a bunch of patients that we saw. This is a 22-year-old college student. She was out with her friend. She's on 5th Street in Dayton in a place called the Oregon District, a very popular night spot in Dayton. And she's at a place called Blind Bob's, which is a very popular bar. It's actually my daughter's favorite bar downtown, as it turns out. And so about midnight, suddenly she starts hearing screaming. She starts hearing loud noises. They figure out very quickly that these are gunshots occurring outside on 5th Street, right outside of Blind Bob's. There's terror out in the streets. There's terror in Blind Bob's as people are trying to run away, but there's no other door that they can get to. They're hiding behind tables. They're hiding behind the bars. And it was a shooting tragedy as a year and a half ago or so. 9 people ended up dead, 27 ended up wounded. As this patient left Blind Bob under police escort a few minutes later after the shooter had been killed, she saw a dead body, she saw ambulances. This was a horrifying thing. Her life was changed forever. We're going to show, just to show a little bit of it, this is actual footage from outside of Blind Bob's. This is a security camera. There's no audio to this, but it's just to show what was going on right outside of Blind Bob's. So just over a minute, 100 shots were fired outside, and this was literally right outside of Blind Bob's. He was trying to get into Blind Bob's at the end, which is where he was shot down. And so now our patient has shown up. It's a couple months later. I'm not going to go over the symptoms of PTSD because you all know those, but this particular patient can't stop thinking about it, is having nightmares and repetitive dreams, tries to avoid reminders if she can. She's certainly not going out with anyone at night. She doesn't even like to leave her room. She doesn't go to classes as much. She is worried that things are going to happen. She's pessimistic about her future. She is scared all the time. She's tense all the time. She has lots and lots of startle responses. So she has this full picture of a PTSD syndrome. So the question is, where are those symptoms coming from? Now, obviously it's from the trauma, but precisely why is she experiencing those things? And that's what we're going to take a few minutes to take a look at. And we're going to give you some of the neurobiology of what's going on in an individual who has PTSD, what's going on in our patient as she is coming in to see you with symptoms. We're going to take a really quick look at neurohormones. These are floating throughout your body. This is the body's normal response to external and internal stress. It helps guide glucose metabolism. It helps guide inflammatory systems, immune responses, and so forth. And the way it works is the hypothalamus is activated by stress. It then releases something called corticotropin releasing factor, CRF, which activates the pituitary to release adrenocorticotropic hormone, which then activates the adrenal glands to release glucocorticoids, including cortisol, which again impacts glucose metabolism, impacts how the body responds. When you're under a lot of stress and you feel that you're catching colds more often, this is part of the explanation for that inflammatory system being altered or tinkered with by this stress response. Now, what normally happens is the cortisol in your system then goes back to the hypothalamus and shuts the system down. So it's meant to be a fairly acute response. But what you see in PTSD is that doesn't happen. CRF is being released into the system, but the levels stay really quite high. Cortisol never goes high. It stays low, it stays normal, and it never shuts the system down. And what you see in any person or animal model where you have high amounts of corticotropin releasing factor is you see anorexia. You're not hungry. you're not eating. Again, under times of great stress, well, some people are nervous eaters, but except for the nervous eater part, when you're under tremendous life-threatening stress, you don't worry about eating so much. And you also don't worry about sleep. And so patients who are individuals with higher amounts of CRF aren't sleeping, aren't eating. So you're starting to see some of these symptoms creep up, but it's much more involved in the neurotransmitter system. So these are in the spaces between the neurons of your brain. And norepinephrine or noradrenaline is one of the prominent ones. This is what's involved in fight, flight, or freeze. So if there was a loud bang and your heart starts racing and your muscles tense up and you sweat, that's all from the noradrenergic system. And what you see in patients who have PTSD is that they have high levels, baseline levels of noradrenergic activity. So they're already kind of running a little hot when it comes to noradrenergic activity, and then they're more reactive. So when things happen, you see a huge spike in their norepinephrine. And that leads to a lot of the arousal symptoms, a lot of the sympathetic nervous system effects. So insomnia, irritability, startle, hypervigilance. All of that is because their noradrenaline system is high and is overly reactive. You will also see changes in their serotonergic system. Now, serotonin is a little bit more subtle or nuanced when it comes to fear and anxiety. I mean, norepinephrine is bam, your heart's racing, your cold sweats, your blood pressure goes up, your muscles tense, your voice cracks, you sweat, you breathe fast. Serotonin is more involved in modulating the fear learning and fear expression, your ability to learn to be afraid of something and how you express fear. So if your serotonin between those neurons goes up too rapidly, you get more fear learning. So you become more afraid more quickly. If the serotonin in those spaces goes up on a more gradual level for a chronic long period of time, then you actually get decreased expressions of fear. So there's kind of this bimodal response. Increasing serotonin too quickly, you get more fear and you become more afraid. Increase it slowly and chronically, and you have less fear. Hold on to that because that's going to become important when we talk about treatment. The glutamate system. Now, glutamate is the brain's primary excitatory neurotransmitter. It just generally turns everything on in the brain. It gets more excited, more aroused, and it shows up in PTSD in a couple of ways. And primarily through its effect on NMDA receptors, which is one of the receptors it activates. And what you'll see is that people with PTSD have higher than normal amount of glutamatergic activity, and that impacts fear learning. Because when you have glutamate in your system, you learn to be afraid more quickly. So something has happened and you learn to be afraid of it more quickly if your glutamate neurons are activated. But also, if you overstimulate these NMDA receptors, you get the formation of memories that are different. And as all of you have talked to folks who've had traumatic memories, you know that trauma memories are different. They feel more vivid, they're in technicolor, they're live, they're intense in a way that most memories aren't. And we think that part of that intensity is because of the glutamate activity when those memories are being laid down. Now, the opposite of glutamate is GABA. GABA is the brain's primary inhibitory neurotransmitter. It's the brain's dimmer switch. It just kind of turns down all levels of activity. It's linked to benzodiazepine and alcohol receptors. So if you were to take a benzodiazepine like diazepam, which is Valium, part of the reason you feel less alert, you feel sleepy, you feel sluggish, you feel slower, is because your GABA is being increased. Your GABA activity is being increased by the benzodiazepine. And what you see in folks who have PTSD is their GABA activity is low. So normally that would be there to calm people down, help them keep focused, and it's low, which makes it hard to function. So you have these altered neurohormonal responses. You have increased glutamatergic activity, which is increasing fear learning and altering memory formation. You have increased noradrenergic activity, which is a lot of arousal symptoms and anxiety and irritability. You have altered serotonergic systems, which affects the modulation of anxiety. And you have decreased GABA, which decreases your ability to function during times of extreme stress. So you see how all of that is working together. Now, this is the ugliest picture of a brain I could find. And I'm going to leave it on there until I start getting some answers in the chat. So that's your ability to get rid of that ugly picture is what brain structures are involved in the creation of PTSD. So go ahead and enter some answers into the chat for me, and we'll take off that very disgusting picture there.
I can't put it in the chat, but amygdala.
Oh, amygdala. Good. That is number one. Thank you, Tessa. Anyone else? Any other brain structures? Type it in chat, or you can unmute if you're bold enough. Go ahead, unmute, please. That'd be great. Or you can chat.
Try the chat now, guys. I'm on a new computer today.
Oh, it's not working.
Things are happening over
here.
here.
So the limbic system, okay. Amygdala, yeah, Tessa's answer got it. It did get in there. Prefrontal cortex, that is correct. That is correct too. The limbic system is certainly correct. Hippocampus, hypothalamus, yep, absolutely. Yeah, that's good. Thank you. That okay, it's up and working. Now that's what I was checking on. I will get rid of that picture. And the reality is a bunch of the brain is involved. This is I took this from a slide on the neurobiology of anxiety and fear, but it's the same systems. And you can see the amygdala is sitting here in the middle of everything. It's kind of processing the incoming information. It's dealing with fear expression to the right hand of your screen. But there's all of these activities, and all the ones in gray are malfunctioning in patients who have PTSD. So we're going to start with the hippocampus that was mentioned in our chat. The hippocampus is involved in consolidating, laying down memories, and retrieving memories. And if you just look neuroanatomically, patients who have PTSD tend to have a hippocampus or hippocampi that are smaller than normal controls. So they have a smaller than normal hippocampus, and it also is not as connected with the prefrontal cortex as it normally would be. So it's smaller than normal, and it's functioning abnormally, and it also appears to be impaired in the way it's working, and it tends to overgeneralize memory. So rather than being afraid of a very specific situation at a very specific time and place, you become afraid, or the memory is associated with a whole array of different memories. And so you get this overgeneralization. So the hippocampus is not working properly. Now, I'm going to refer to the Salience Network, and that includes a couple of different things. It includes the amygdala, which several people mentioned, the insula, which is on the folding of the temporal lobe, and the dorsal anterior cingulate cortex. And what the Salience Network does is it helps you focus and pay attention to things that might harm you. So if I'm sitting here talking to you, and I feel a twinge in my side, well, I'm not going to pay attention to it, right? Because I have to think of what's on my slide. I'm thinking about my audience. I'm thinking about what's coming next. What do I need to say? What are the primary points? But there might come a point where that pain in my side becomes so severe that my brain suddenly says, hey, you better pay attention to that. That's really important. That's my Salience Network kicking in, saying this internal situation needs to be addressed. And what you see in patients with PTSD is that entire Salience Network, the amygdala, the insula, and parts of the anterior cortex are overly active and overly reactive. They're being triggered even though there's not really a threat. They're being activated even though nothing bad is going on. So, so you get this overactivation. The locus coeruleus, very similarly. That is the home of a lot of those noradrenergic neurons. That's where all that norepinephrine is being produced. It's involved in fight, flight, or freeze activities, and it too is overly active and overly reactive in patients with PTSD. So there's someone shuts a door down the hall and it bangs slightly. Most of us not going to be worried about it. That patient with PTSD, they have a sudden spike in their norepinephrine, and they're going to feel afraid. They're going to feel that something bad is happening. So our patient, this young woman who is out in blind bobs, is having overactivation of her amygdala, her locus coeruleus, her insula, all of which makes her feel constantly a threat, all of which has her scanning her environment for what's causing this terrible sense of fear that I'm feeling. And even when there's nothing bad going on, she's feeling a threat. Now, what's normally supposed to happen is there are other parts of our brain that dampen that anxiety, dampen that fear. One is the medial prefrontal cortex. So if you were to, right underneath this part of my head, is the medial prefrontal cortex. It detects and manages emotional response, right? There isn't much difference physically between being very afraid and being very excited, right? In both cases, your heart is pounding, your blood pressure is up, you might be shaky, your voice might crack. The big difference is the emotional valence that you put on there, and that's that cognitive interplay, and that largely happens in the medial prefrontal cortex. The medial prefrontal cortex is also involved in habituation. So if I were to take you to a tall building, 4 or 5 stories high, and I were to have you lean out over a guardrail and look down, almost all of us would feel afraid, right? Our heart's going to be pounding, we're going to feel a little bit shaky, we're going to feel nervous. But if you stayed there for 45 minutes and nothing bad happened, you would feel less afraid. That's habituation, and the medial prefrontal cortex is involved in that. And in patients with PTSD, it's not working properly. The rostral part of the anterior cingulate cortex and the front part is a very central part of the brain. It too is involved in cognitive and emotional interactions, and it's involved in extinction. So habituation is if I took you up there and had you lean out for 45 minutes and you learn not to be afraid because nothing bad's happening. If I took you up there 10 days in a row and did the same thing and nothing bad happened, then by day 10, you're going up, you're leaning out over, you're not feeling afraid at all. That's extinction, learning to not be afraid or to unlearning fear. That is extinction, and the anterior cingulate cortex is involved in that. And in patients with PTSD, that part of the brain is smaller than normal and less active than normal. Again, you're not able to calm yourself down. And finally, the dorsolateral prefrontal cortex, so that part of your brain on the front outside, that's involved with decision making, making plans for the future, just choosing options, and controlling what you do, executive functioning. And in patients with PTSD, it's less active, less engaged, and less connected. They're not able to control themselves. So that veteran who's going to fireworks, and I know this is fireworks. I know there's nothing bad happening to me. I know I'm not in danger. Still, when the fireworks start popping off, they start feeling terrified. That's because that dorsolateral prefrontal cortex is not able to regulate their emotion. They get to the point where they have to leave, right? They're unable to make normal, rational decision making. And that's because the dorsolateral prefrontal cortex is not functioning properly. So here's what we have. We have these altered memory formations, that's through the hippocampus. We have this increased fear response through the Salience Network and the locus ceruleus. We have decreased habituation and extinction, and we have decreased conscious control over emotions and functioning. And we can look at that actually occurring in the brain in real time, actually, through functional MRIs. So that's why this patient is having these symptoms. And so when we come up with treatment, we should want to counteract those effects. We want to counteract those occurrences in the brain. Now, another chance for a chat. Okay, there we go. So let's see. What is the most popular medication to take after a traumatic event? Please enter your thoughts in the chat on this one. Most popular drug of choice after a traumatic
Are you
event.
asking for prescription drugs or like?
Not necessarily.
Oh.
Beta or alpha blockers, okay, we'll come back. Alcohol, yeah, see, so Dr. Boltry got to the key of the question, which was the most common medication after the traumatic event is alcohol, right? Think of it. How many times after a bad day do people go get a drink? There is the cops will have a bar that they all go to. Firefighters have their bars. There's usually a bar across the street from the emergency department, right? When you've had a bad day, you go and take alcohol. That's the normal, typical response to trauma. It's not been randomized, controlled tested, so I'm not recommending it. But we can also now start figuring out why do people do that. And we have a really nice neurobiological reason. Alcohol works in part through the GABA system. And as I mentioned before, GABA activity is decreased in people who have PTSD. And drinking alcohol increases GABA. It diminishes arousal, it diminishes salience, you're not feeling scared, you're not focusing on stuff, you're not as worried as you were before, and you feel better. But GABA also impairs extinction learning, and it impairs self-control. So what you would expect to find, which is exactly what we do find, is that it makes you feel better in the short term, but it doesn't help you get better in the long term. It's true of alcohol, it's true of the benzodiazepines as well. It makes sense that it feels good, but it actually doesn't help, and it might even defeat some of the things that are trying to help you get better. So going back to more formal treatments, if you look at most of the, actually all the studies I'm aware of that examine treatments for PTSD, the most supported is trauma-focused psychotherapy. They tend to, in meta-analyses and in comparisons, they tend to outperform all medications and non-trauma focused therapy. The effect seems to last long after therapy is done. And all of the trauma-focused psychotherapies have one or two of the following components. They have a cognitive component where you look at the thoughts that are associated with the trauma and you challenge the thoughts that are associated with the trauma. You start thinking about things like safety and your safety and will I ever feel safe again and what power and control do I have over situations. And so you force them to think about the trauma in a logical, consistent manner. And if you look at what that's doing in the brain, it's activating the dorsolateral prefrontal cortex. The other component that you see in trauma-focused therapies is an exposure component. Either in real life or through the imagination or storytelling, you're having them expose themselves to the frightening thing. And what that does is it engages habituation and extinction. And if you were to look at that, the functioning of the brain while they're going through that, you will see activation of the medial prefrontal cortex and the anterior cingulate cortex and decreasing activity of the Salience Network. So you're engaging those parts of the brain that have been underactive and you're diminishing those parts of the brain that are overactive. Now with medications, when you look at trials of medications, the most successful category of medication are the antidepressants that have some kind of serotonin component. Serotonin reuptake inhibitors, either selective serotonin reuptake inhibitors or serotonin norepinephrine reuptake inhibitors. Those are the ones that are most globally helpful. In this one meta-analysis, the three most effective were paroxetine, fluoxetine, and venlafaxine. The only two FDA approved are paroxetine and sertraline. Everything else is off-label. And this seems to be working through the amygdala and by manipulating serotonin. And as we had talked about before, if you gradually and chronically increase extrasynaptic serotonin in the amygdala, you have decreased expression of fear. So it works over time. And what you would expect to see, and in fact, what you do see, is that after being on these medicines for weeks at a time, you see decreased amygdala hyperreactivity and gradually an increase in dorsolateral activity, prefrontal activity, as you realize I'm not feeling afraid. Now there's a couple of comments in there, and we'll come back to these, about other medications like the beta blockers and the alpha blockers like prazosin. And those work by directly targeting that noradrenergic storm. Now, they haven't been found to be as effective in the full treatment of PTSD symptoms. They're usually most effective in dampening that kind of hyper arousal. So preventing nightmares, preventing kind of, I don't want to say preventing panic attacks, but preventing the symptoms of a panic attack. So what our patient, our 22-year-old who was in that bar, has survived, is now having symptoms. Well, her symptoms are coming from an overactivation of that Salience network, right? She's being told, you are in danger, there's a threat, you are going to be hurt. And an underactivation of the parts of the brain that control that. So she's unable to talk herself down. She's unable to feel in control. She's unable to say, don't worry, it's not really a problem. So what we're doing with treatment, what we would like to do with treatment, is some way to decrease that overactivation of the Salience network. And we can do that by extinction or habituation. We can also do that by chronically increasing serotonin activity in those neurons of the brain. And we also want to increase the activity of the top-down control. And we can do that through cognitive strategies, talking to her about her safety and how safe she feels and what the real threat is of going out with friends and what the real threat is of going to school. Forcing her to think about that would help increase her top-down control. So basically, the neurobiology says we should be recommending things like trauma-focused psychotherapies and the SSRIs or SNRI antidepressants, the very thing that the clinical trials tell us is helpful. And it leads to the not terribly surprising conclusion that the things that work because they change the neurobiology. Now, our minds are all blown by this, right? We always assumed that was going to be true. But really in psychiatry, for about the first time, we can draw a really pretty tight link between what has happened, what changes in the brain, what we can do to manipulate the brain to lead to an improvement of symptoms. So that is my last slide. I will stop sharing if there are comments or other questions.